Hello, my name's Florence. Welcome to theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 140, Low-Lying Placenta, or Placenta praevia. I've got some fantastic guests coming up on the podcast. Some really great people, and we're going to have some brilliant conversations. But actually, when I look at the numbers of downloads for episodes, often my most popular episodes are clinical topics. So today I'm reverting back to a clinical topic. Placenta praevia, a low-lying placenta. In fact, I'm slightly confused that I haven't covered this before. I've touched on it in my episodes on excessive blood loss, bleeding or hemorrhage, and I've also touched on it in perhaps my episodes on ultrasounds and the placenta. But I haven't dedicated an episode to a low-lying placenta, so I thought I'd do that today. There aren't many absolute indications for a caesarean birth. And when I say an indication, that means a reason why one absolutely ought to have a caesarean. But a low-lying placenta is one of them. What do I mean by a low-lying placenta? Well, the placenta, as you now know, is the interface between the mother and the baby. It's formed mainly of tissue derived from the fertilised egg, and it attaches to the wall of the womb. And the mother's blood vessels combine with those fetal cells to make the placenta. The blood vessels dilate and give an enormous amount of blood so that the baby gets good oxygen and nutrients transferred through the placenta to the baby. A low-lying placenta is when this implantation process happens at the bottom end of the womb, close to the cervix or neck of the womb. Why does this matter? Well, it can matter if actually it's all across the cervix. Because to be born, the cervix has to dilate, the neck of the womb, open up, and the baby's head pass down through the birth canal. If the placenta, the afterbirth, is covering the cervix, the neck of the womb, then that isn't possible. Partly because it's obstructing the way out, the opening, but also because as the baby starts to make that journey and the neck of the womb starts to dilate and open up, excessive bleeding occurs, which poses a risk to the health of both mother and baby. Part of the routine 20-week anomaly scan, therefore, is to check the position of the placenta. At this point in pregnancy, quite a lot of women will have a low-lying placenta. That's because the bottom part of the womb hasn't grown as much at this stage of pregnancy. It develops later in the third trimester. Therefore, women who are noted to have a low-lying placenta at this 20-week scan will be called back for a further scan later on in pregnancy. And for 90% of those women, the placenta will have moved. Actually, that's not true. The placenta doesn't move, but it appears to move in relation to the cervix. Obviously, the placenta is actually planted onto the wall of the womb, so it can't physically actually move away, but because the bottom bit of the womb grows more in the third trimester, If there's a gap, however small, between the cervix, the neck of the womb, and the lower edge of the placenta, this gap will get larger as the bottom of the womb, or the lower segment of the womb, develops. Therefore, 90% of women that had a low-lying placenta at 20 weeks, when they're rescanned maybe at 32 or 34 weeks, the placenta will no longer be low-lying. It won't be in the way, and we can tell them it's perfectly safe to have a vaginal birth, and they're not likely to have complications of excessive bleeding. This leaves us with the small number, around 1 in 200, for whom the placenta remains low-lying. That may be that the placenta is up to or very close to the opening to the neck of the womb, or even across the neck of the womb completely. In the past, we used to classify things into major placenta praevia, where this was the placenta right across the neck of the womb, and more minor placenta praevia, where it was up to or close to the neck of the womb. These days, a scan will be done with an internal scan, a vaginal scan, so that we can examine very closely the relationship between the internal os, that's the internal opening of the neck of the womb, and the leading edge of the placenta. The placenta needs to be more than 20 millimetres, that's only 2 centimetres, away from the internal os, the internal opening, for a woman to be able to have a vaginal birth. This can seem like a very small measurement, and a measurement that's very important to get accurately, because it can be the difference for a woman between a major operation and a straightforward birth, potentially. When the placenta remains right across the cervix, it's very unlikely it's going to move. It's going to be there. It's going to be obstructive and potentially risk bleeding. Some women with placenta praevia are very lucky. They don't experience bleeding during pregnancy. They can stay home, have normal antenatal care, and be admitted at the time that we want to do a planned caesarean. But some women with placenta praevia or a low-lying placenta will experience significant bleeding during their pregnancy, a so-called APH or antepartum hemorrhage. This may be a small amount of spotting, bleeding on wiping after going to the toilet, or can actually be a very heavy blood loss. Typically, bleeding from placenta praevia is painless. The woman may not have any warning. She doesn't have any cramps or contractions, and she'll just suddenly start bleeding. She may initially think she's wet herself or that her waters have broken, and then she'll look down and discover it's fresh blood. If a woman's admitted with bleeding, she may end up staying in hospital for some time. We'll certainly want to keep her for at least 24 hours at a very minimum, and that's only if there's a very minor amount of bleeding, because a small amount of blood loss can herald a bigger bleed. We'll want to know that she's okay and that her baby's okay. We'll put an IV cannula in, that's a little plastic tube, into her vein so that we can give her fluid or blood should it be needed. And we'll take blood tests to look at her iron levels, her haemoglobin levels, and to cross-match up blood just in case we need to go ahead and do the caesarean at that point. If there's heavy bleeding, but the woman's pulse and blood pressure is stable and she's well, and her baby's heartbeat is also normal and stable, we may tolerate quite a significant amount of blood loss before going in to deliver the baby. Because at an early period in pregnancy, maybe 28 or 30 weeks, there's a lot of benefit to keeping the baby in the womb. It's got a lot of growing and maturing to do. Sometimes, even if the bleeding is heavy, if the woman and baby are stable, we may need to give her a blood transfusion rather than intervene and do the caesarean at that point. Some women have recurrent bleeds, And this can be very tedious for them because we'll end up saying, you really need to stay in hospital until your baby's born. They can have bleeding on and off, or bleeding over a period of several days. It may all settle down. We may say, okay, you can go home, perhaps if it's their first episode of bleeding. And then sure enough, they'll come back with another. So unfortunately, if you have a low-lying placenta and you're having bleeding on more than one occasion or of a considerable amount, your doctors are likely to recommend that you stay put, stay in hospital, just in case. As we get closer to the due date, the threshold for intervening and delivering that baby gets lower and lower. The baby doesn't need as much time to mature, and we don't want to put the woman's health at risk if she's having substantial bleeding. The other issue that can happen is that the bleeding from the placenta can start to trigger contractions or uterine activity, period pain, tightenings. And if the womb starts to contract, then that is potentially going to make the bleeding worse and perhaps trigger labour. So the closer you get to when we would be planning to deliver the baby, the more likely we are to intervene at a lower level of blood loss. During pregnancy, we're very likely to suggest you take iron tablets, even if your blood count's pretty good. And if you don't respond to iron tablets, we may give you intravenous iron to top you up so we can get you in the best possible shape for having your caesarean, because a caesarean for placenta praevia, low-lying placenta, is more complicated and more likely to have a higher blood loss than a caesarean for some other reason. If you haven't had any bleeding during pregnancy, we'll often suggest doing a caesarean a little bit earlier than we might otherwise, perhaps 38 weeks, perhaps in the 38th week rather than the 39th week, just because we don't want to risk you having a big bleed at the end of pregnancy for no benefit to your baby. Okay, so you're going to have your caesarean now. What are the things that we obstetricians are thinking about? Well, we need to work hard with the anaesthetist to prepare everything before you go into theatre. Most caesareans for a low-lying placenta can still be done under a spinal anaesthetic, but our anaesthetic colleagues will give fluid before they give the spinal anaesthetic so that we're diluting the woman's blood a little bit so that if she does bleed, she's not losing as many of her blood cells as she might otherwise. We'll also always cross-match blood, that is, get blood matched up ready to give to you in case you need a blood transfusion, because the risks of heavy bleeding with a caesarean for a low-lying placenta are greater. They're particularly high if the placenta is at the front or anterior low. And that's because we may need to go round or sometimes even through the placenta to deliver the baby. We may suggest that we do an ultrasound scan when you're on the operating table so we can accurately locate the placenta before we make the incision on the womb. This way we can try and avoid the major blood vessels serving the placenta if at all possible, but sometimes it just simply isn't feasible. The other thing we'll be checking by doing that portable ultrasound scan is the position of the baby, because if the placenta is right across the neck of the womb, blocking the entrance to the birth canal, the baby is more likely to be in an awkward position. Sometimes a baby can be transverse, that's lying horizontally across the womb, or oblique, diagonally, rather than being the most common head-down position. So we'll want to know what position the baby's in so we can get hold of it easily when we open the womb, because as soon as we make that incision on the womb, you're likely to start bleeding. There's some guidance from the Royal College of Obstetricians and Gynecologists and the Royal College of Anaesthetists that mean that if you're having a caesarean for a low-lying placenta, you should have a consultant anaesthetist and a consultant obstetrician present in the operating theatre. This is because of the higher chance of excessive blood loss, and to make sure that your operation is as safe as it can possibly be by having senior members of the team present. Depending on whether it's a planned operation or we're doing it because you're having active bleeding at the time, will also depend on whether we have paediatricians present to check on your baby. On the whole, most of the blood loss that you lose from a placenta praevia is actually the blood of the woman and not that of the baby. But obviously, if a woman is losing a considerable amount of blood, we worry about the impact that may have on the baby's well-being too. As obstetricians, when we're taking a consent for a woman who's having a caesarean for placenta praevia, we'll always talk to her about the extra medication we may give to make the womb contract down after the baby's born, to constrict the blood vessels. And we'll also talk to her about other surgical things we might do, such as putting a balloon inside the womb to press and compress those blood vessels. There are one or two other surgical tricks we can use. I was always taught by a consultant colleague when I was more junior that taking a little bit of oxytocin, the hormone that makes the uterus contract, and diluting it with a bit of saline in a syringe and just using that with a needle to just inject a little bit into the placental bed would help constrict the blood vessels so that I could see a bit more easily where to place my stitches. Usually at a caesarean birth, once we've delivered the baby and delivered the placenta, we stitch up and close the womb straight away. But sometimes with placenta praevia, if there's a lot of bleeding happening from what we call the placental bed, the place where the placenta has been, we will actually put some stitches into the placental bed, again, to try and constrict and tie off those blood vessels. So sometimes we put in what's called a figure of 8 hemostatic stitch. That means that the stitch loops round a bit like the number 8, and then we tie a knot. And that occludes the blood vessel that might be bleeding and reduces blood loss. Otherwise, if you're not careful, you can close the womb and actually find that the woman is still bleeding, but the blood is making its way down the vagina. So the other thing I'll sometimes do when I'm doing a caesarean for placenta praevia is I'll ask the midwifery support workers to have a peek under the drapes and tell me, does everything look okay? Or is actually there a lot of blood between the woman's legs? We'll not only be talking to the woman, but also our anaesthetic colleagues. What's her pulse and blood pressure doing? And we'll be weighing the swabs we're using and measuring the blood that's going up into our suction tubing so that we can get a very accurate idea of how much the blood loss is. On the whole, pregnant women are very able to tolerate quite a considerable amount of their blood volume being lost. If the low-lying placenta is actually posterior, so at the back of the womb, and we haven't had to go near it with our incision on the front of the womb, then actually blood loss from a placenta praevia caesarean may be similar to that from an uncomplicated caesarean birth for some other reason. But if the placenta is anterior and we have potentially gone through the edge of it, or sometimes even through the middle of it, then it wouldn't be unusual to lose 1.5 litres or even 2 litres of blood. Like I said, we can give lots of extra medication to help the womb contract down and constrict all those blood vessels, as well as using surgical techniques, our stitches, the balloon I mentioned. But we do warn women having a caesarean for a low-lying placenta that there's a slightly higher chance, if there's uncontrollable bleeding, of needing to do a hysterectomy, that is, removing the womb altogether, if the bleeding should be life-threatening. It's unusual for us to need to do this. And so it can be difficult to have those conversations with women. It can sound extremely alarming. You're going in to have a baby And then the next thing, we're talking about hysterectomy, which takes away any possibility of any babies in the future. It's really frightening. So this conversation has to be sensitively done. And ideally, we've either done it while the woman's on the ward and been an inpatient for a while with us, or during the antenatal appointments during pregnancy, so she's had time to get her head round it, ask questions, have good information. It shouldn't be a surprise on the day that we're having that conversation. It's very much, for us, the last resort. We really don't want to be doing that. But we do know that for a small number of women, that can be a life-saving procedure. And that's why it needs to be thought about. Back to the antenatal period. If you're found to have a low-lying placenta anteriorly, so at the front of the womb, if you happen to have had a previous caesarean birth, we'll get a specialist fetal medicine scan of the position of that placenta, because we need to look very carefully at the interface where the placenta has implanted into the womb, because there's a rare condition called placenta accreta, where the placenta has abnormally fixed into the muscle of the womb. And this becomes increasingly common when a woman has had a caesarean birth before, or possibly many caesarean births. And this is called placenta accreta. This is a very different complication, because with placenta praevia, a low-lying placenta, once the baby's born, the placenta will come out, and then we can do our stitching, give our medication, and do all these things to help prevent bleeding. When we're removing a placenta, normally what happens is the placenta starts to separate. And if it doesn't separate, we can slip our hand and gradually ease it off, peel it off, as it were, the wall of the womb with our hand. There's a clear distinction between the placenta and the wall of the womb, and I can just gradually run my hand between the two and separate and pull off the placenta. With placenta accreta, that isn't possible. The placenta has embedded itself into the myometrium, into the muscle of the womb. And that means that if I disrupt that placenta, the woman will have uncontrollable, life-threatening bleeding. I have experienced some cases of this in the past, and this placenta accreta needs a very, very different approach. These days it's recognised that actually this needs very different surgery. And so if this is identified on ultrasound scan, which it should be in the antenatal period by having a specialist scan, we will actually refer these women to our local tertiary unit, our specialist unit, where they undertake something called a triple P procedure, which is a specific, special sort of caesarean birth, which needs a specific expertise and multidisciplinary team approach with anaesthetics, obstetrics, paediatrics, radiology, haematology. There are a small number of centres now in the UK that specialise in this sort of birth. And whilst it can be very frustrating if you've chosen to have your baby somewhere and then you're told you really need to go somewhere else because you've got placenta accreta, then absolutely I would urge you to take that advice and go to that regional centre, because that way you'll have the best possible care for this very rare condition. I think that pretty much brings me to a zesty bit. My zesty bit would be, if you're a woman with a low-lying placenta, know that you're in good hands. We know what we're doing. We'll do our utmost to prepare you. Yes, we will have to have some potentially scary conversations with you, but know that for most women with a low-lying placenta, everything goes very well, and you will have the most senior staff available in your surgery. It may be that you end up in hospital for a considerable period of time if you have bleeding. Be patient. Bring stuff to entertain yourself. Get people to come in and visit. Get people to bring you some decent food. But no, whilst weeks in hospital can seem absolutely awful, particularly if you've got other small children, it's an investment. And in the fullness of time, when you look back, it won't actually feel that long in the greater scheme of things. And if you've had bleeding, it really is the safest place for you to be. For maternity staff looking after women with low-lying placenta, I think we need to think carefully about how we have the conversations with women, making them aware of their increased chance of bleeding and the problems that might be encountered, but also not alarming them, using language and thinking through carefully how we give them that information, and perhaps doing it over a series of appointments or series of conversations so it doesn't seem too alarming to have too much all at once. I very much hope you found this episode of the theobspod interesting. If you have, it'd be fantastic if you could subscribe, rate and review on whatever platform you find your podcasts, as well as recommending the theobspod to anyone you think might find it interesting. There's also tons of episodes to explore in my back catalogue, from clinical topics, my career and journey as an obstetrician, and life in the NHS more generally. I'd like to assure women I care for that I take confidentiality very seriously and take great care not to use any patient identifiable information unless I have expressly asked the permission of the person involved on that rare occasion when it's been absolutely necessary. If you found this episode interesting and want to explore the subject a little more deeply, don't forget to take a look at the programme notes where I've attached some links. If you want to get in touch to suggest topics for future episodes, you can find me at theobspod on Twitter and Instagram, and you can email me theobspod@gmail.com. Thank you for listening.